Okay, welcome back from lunch, everyone. Hopefully you will stay awake at this time. This is not the best timing for a lecture. I'm going to do my best to stay at the podium. I usually walk around when I teach this type of topic, but I will do my best. I'd like to start off by saying it's always a privilege for me to stand up here and talk about this particular topic. It's a little bit different, I think, than what we've talked about so far, but it will have some crossover ideology, as you'll hear as I talk. I'm going to try to stay on time. I usually spend a whole day teaching about this. One of my functions is within our state quality collaborative, doing full-day trainings on trauma-informed care practices. So to give you just an introduction in about 18 minutes, as you've heard from other speakers, is incredibly difficult. But think of it as this introduction to what trauma-informed care practices look like, how can they be employed, and what's our role as obstetric anesthesiologist in bringing this into the patient experience. And just briefly, if anyone has any stress listening to any of this, because I know by statistics many of you out there come with your own histories of trauma, please take care of yourselves. Self-care, if you need to get up and leave, please do so. Come back when you feel like you want to, or you feel like you can. A focus today with trauma-informed care is that I want people to understand it is not just for people who've survived trauma. It can be used as a universal precaution, and I hope I can convince you of that as I go forward. Okay, as far as objectives, if you're not familiar with trauma-informed care, I will teach you about the 6 pillars that are at the core of implementing this type of care. I also want you to know that trauma-informed care is not a checkbox activity. You don't get to go home today saying, oh, check the box. I had a trauma-informed care lecture. I'm good to go. It is not like that. It's a cultural shift, and it takes time. Again, understanding this as a universal precaution and not something that is used exclusively for survivors of trauma. And then lastly, what is our role as obstetric anesthesiologists or anesthesia providers in this space? How can we prevent trauma? How can we prevent traumatization and re-traumatization? As far as disclosures, I own my own website where I post patient narratives. I also have a role in an AI company, but neither of my roles preclude me from delivering a very unbiased presentation today about trauma-informed care practices. So, to get started, I think it's important for people to understand what we're even talking about here. This is not necessarily physical trauma that we're talking about, it is psychological trauma, even though the two are often entwined. So I love this definition as a general concept of what psychological trauma is, and it comes from Judith Herman's work with rape survivors. And I want to share this with you. And as I read it, I want you to pay attention to specific words that I highlight. So psychological trauma is an affliction of the powerless. So it's powerlessness. At the moment of trauma, the victim is rendered helpless by overwhelming force. When the force is that of nature, we speak of disasters. When the force is that of other human beings, we speak of atrocities. Traumatic events overwhelm the ordinary systems of care that give people a sense of control, connection, and meaning. Control, connection, and meaning are taken from people during traumatic events. These events are extraordinary not because they occur rarely, but because they overwhelm human adaptations to life. They confront human beings with the extremities of helplessness and terror. Okay, so powerlessness, helplessness, terror, loss of control, connection, and meaning. This is at the root of a traumatic experience for individuals. Now, the DSM-5 defines trauma a little more specifically in it that it says an individual must be exposed to death, threatened death, actual or threatened serious injury or sexual violence. Now, this exposure does not have to be direct exposure by the individual. It can include witnessing the event happening somewhere else. A lot of people that witnessed the 9/11 incident developed post-traumatic stress afterwards, considered that a traumatic event for them. Additionally, learning that it's a relative or close friend experienced something traumatic can also be a trauma. This can include the life of one's unborn child, can constitute a trauma. Also, indirect exposure, which is also called vicarious trauma, secondary trauma, our trauma. This is what happens to many of us, sometimes on a daily basis, in the workplace. It has only been, I'd say, in the last 14 to 15 years now, that perinatal mental health specialists have included negative events around childbirth as meeting the definition of a traumatic event. That's somewhat recent. PTSD didn't even come on the scene until 1980. But now that we are able to include events around childbirth as being traumatic or meeting this criteria, we now have a way to identify and I guess that's right, identify this collection of symptoms that patients were going home with that previously weren't identified. And these include symptoms in the categories of intrusion, like nightmares and flashbacks, avoidance behaviors, negative cognitions and mood, so not just depressive symptoms, but also self-blame, guilt, anger, and hyperarousal, which included anxiety, hypervigilance, panic, sleep disorders. It's really important for me to state here as well that trauma is in the eyes of the beholder. And what one person might tell you is traumatic might not look the same way from our perspective. And it's very important for us as providers or support people to not triage someone else's emotional experience based on how we think they should feel. And in some discussions yesterday evening, some of the classics came up, like, you should be happy you had a healthy baby. Aren't you grateful they saved your life yesterday? What that does often is it dismisses the chance for that person to express the negative emotions that they are feeling, because they can feel both at the same time. I also want to mention here that traumatic experiences and complications are not the same. One can experience significant complications, those that have ICD-10 codes in the chart. Patient goes to the ICU, major hemorrhage, etc. But they might say, Dr. Vogel, I felt supported, I felt safe. I didn't feel like I was going to die. Yeah, it wasn't fun, but I don't have mental health complications. And the flip is also true, that you don't need physical complications to have a trauma, right? So traumatic events can happen without any physical or identifiable complication. So keep that in mind, because it makes it a little more challenging when we're trying to understand who's had a traumatic event. Another definition of trauma, which I think is really useful, comes from the Substance Abuse Mental Health Services Administration. And it's generalized, but also very specific. And what it says is that individual trauma results from an event or series of events. So if you think about trauma as your big T or little t traumas, it can be a series that is experienced by the individual as negative, harmful, life-threatening, and has lasting effects. And these effects can be not just on their psychological well-being, but also on their physical state, their social state, even their spiritual selves. So let's shift now and let's talk about this concept of what is trauma-informed care. Now that you hopefully have a little base of what trauma is, what is trauma-informed care? Well, this concept and construct has really been around since the 1970s. It came out of the voices from rape crisis centers, as well as those working in the child abuse space, and started to say, hey, we need to do something differently for these groups of individuals. Fast forward, 1980, we had the first definition of PTSD, which primarily came from work with combat veterans. Fast forward, late 80s, we have the VA administration with the first Center for Traumatic Stress, and now we have the Substance Abuse Mental Health Services Administration. Okay? So trauma and trauma awareness has now become more mainstream through a variety of different sectors. So what does it mean to use trauma-informed care? Right? It is a cultural change, as I mentioned. It's not a checkbox activity. It's a shift. And classically what you'll hear is that it's a shift from saying to someone, instead of what is wrong with you, to what has happened to you to bring you to this place, right? So shifting from pointing blame, but understanding that something happened to them to bring them to where they are. Another way to think about it as providers is a shift from us directing care without involvement of the patient. We are going to do this to you today, instead of what can we do together, given where you come from, to achieve a mutually agreeable goal. Right? It's a real shift in how we approach not just patients, but even each other. One that I like to think of is this shift also from seeing a patient as difficult, the difficult patient in room 3, Dr. Vogel, the mean one, the non-compliant one, the problematic one. Right? If we could shift from thinking of them as problematic to symptomatic, would that change how we see them, and would that change how we interact with them? And really get at this perhaps this bias that we have. And an example that I'd like to give is if you were in a patient room and they were using what you considered inappropriate language, they were mean or nasty, put your words to it, and maybe a little combative, but your colleague came in and said, oh, by the way, her glucose is 26. Okay, so you know what to do. You know that symptoms of hypoglycemia look like this. You order the right treatment, and you go home without carrying that burden of, boy, that patient was nasty. Could we do that when we understand what trauma behaviors look like? And we could say, oh, that person has having an acute stress response because they come from a history of trauma. They're being triggered right now. I know what to do because I'm trauma-informed. And I go home that night leaving satisfied and not feeling like I was attacked by a patient. It's different. And then also is this unbiased, non-judgmental approach that acknowledges an individual's cultural context. Now, it does have structure. So trauma-informed care from SAMHSA, Substance Abuse Mental Health Services Administration, gives you 4 R's. We're all used to these R's, right? Realize how widespread and pervasive trauma is throughout our culture in a variety of different ways. And trauma can be interpersonal trauma, which can be things like adverse childhood experiences, child abuse, sexual assault and rape, intimate partner violence, medical-based trauma, birth trauma. It can be community-based traumas, collective traumas from racism, from community violence, bullying, etc. But understand, too, that not only is it pervasive, but there are paths towards healing. Just because someone has experienced trauma does not mean that they can't heal from it and have post-traumatic growth. We need to know what it looks like. What does it look like in us if we've had trauma and we're trying to interact with a patient, but we don't recognize that we're being triggered in this circumstance? Can we give care that's appropriate in those circumstances? We need to recognize it in ourselves. We need to recognize what it looks like in our patients, in their families, etc. Respond, meaning learn about it, learn what causes trauma, and change the practice. One specific example that I'm going to give is that we've learned through the research, through patient narratives, that restraining women for cesarean delivery, especially when they are awake and have autonomy, is harmful, psychologically harmful. And it's usually not indicated in most circumstances from a self-harm perspective. So if we're continuing to do that, we need to make change, a policy change that says we're going to do something that prohibits or prevents this trauma from occurring. and actively seeking to resist re-traumatizing individuals that we know already have trauma, and you can learn to resist traumatizing people in the first place. Now, the CDC has expanded into these 6 principles of trauma-informed care. And you'll hear these throughout some of these other talks as well, because they're core components to other types of constructs. Safety. This is why we're here. It's an amazing conference, and I'm so excited that we're including psychological safety as part of the Anesthesia Patient Safety Foundation. Trustworthiness and transparency. So we have to learn to establish trust, because it is no longer a given for any of us anymore, if it ever was. We have to learn to establish trust, and how do we do that in 5 minutes? Peer support, collaboration, that word's been used a lot already at this conference. Empowerment, how do we give a patient a voice and choice and a sense of control? And then understanding them in their cultural context. This next slide, I rolled it out for the first time last week at a presentation. I've been wanting to do this because I kept reading about all of these things that are circling around out there and how much they all overlap. We're all aiming for the same goal. So I put this up so people could understand. We have the 5th R from the AIM bundles, which is phenomenal. Respectful maternity care. We need that, absolutely. Trauma-informed care incorporates some elements of respectful maternity care, such as the cultural context, safety, empowerment, voice, and choice. Looking at shared decision-making, by definition, it's collaboration. So it fits the collaboration, but also, again, empowerment. Are we listening to the patient? Trust, safety. Patient-centered care, focusing on what does this patient want? What do they value? What do they need from us? Again, collaboration, safety, peer support. Trauma-informed care incorporates all of that, but it also allows for an understanding of trauma. It also allows for the understanding that there can be paths towards healing and resilience, and it also incorporates what's happening to us. Because trauma-informed care is also about our own traumas, so it's important to take that into consideration. Trauma-informed work starts with trauma awareness and builds to perhaps a trauma-responsive, healing-centered system. And I'm going to say systems because systems have to evolve just like individual providers in this space. So what does it mean to be trauma-aware? It means you get a lecture. You learn what is trauma, what are the ACEs, adverse childhood experiences, what are the positive childhood experiences, what does chronic traumatic stress look like in adult survivors, what does an acute stress response look like? So that comes with awareness. What does trauma look like? Okay, then the next step, which I think is the hardest, is getting to a trauma-sensitive state. Can you see something from someone else's perspective? Can you do it? And what does it take to get there? Now it's starting to incorporate some of those 6 pillars into your care, putting that into your plans for delivery. That's trauma sensitive. When you are trauma informed, you're building policies, protocols. All of your practices are becoming trauma informed. You sit and you interact with patients in a different way. And then by the time you get to that healing-centered, responsive system, now you're adding this proactive adaptability, which means collect some data. Talk to your patients. Is this working? Are we doing the right thing? How can we improve? And you're using this in every aspect of your system. Everything from your office staff to the people that answer your phones to the clinicians doing the work. And I wanted to mention one newcomer, sort of, on the scene right now, is this concept of trauma-disrupting care. I always thought about trauma-disrupting care as kind of the natural thing we should be doing, which is trauma prevention. But this construct also includes a couple of other, I think, very interesting concepts within it. It hasn't been studied yet, but it's just a construct. But it puts structural oppression at the center of birth trauma. Systematic, structured oppression. It recognizes traumatic situations occurring in real time and basically saying we need to respond to that, learn to recognize it and respond in real time. And I think also what's important here is that it includes reflexive practice for providers. I think that's key. I think this is something that's going to be coming down the road, is we need to do some self-reflection on our own traumas. How do we interact with patients? What are our biases? How can we overcome them? How do we identify them in order to get at a lot of the disparities in the healthcare field? A couple slides on why we need this. I think you have heard a lot of that already today, but as I mentioned, there's a lot of pre-existing trauma that can occur, interpersonal, it can be from natural disasters, wars, community-based violence. That can happen before pregnancy. But there are a lot of traumatic events, a lot of complications that occur that have been studied and have been shown to increase the risk for traumatic birth experiences and possibly postpartum mental health issues, including PTSD. So we have fetal neonatal, and I don't think anyone here would be surprised, with a fetal loss or a neonatal loss. That can be traumatic. But so can 1 hour in the NICU, can be very traumatic. The separation of mother and child can increase the risk. Obstetric-related issues. We've been talking about hemorrhage, sepsis, ICU admissions. But emergencies can be very scary when 30 people run into the room for a code O, or whatever you call it, yours at your institution. Also, some of the interventions that we use to prevent some physical complications like hemorrhage, when we do manual extractions of clots without the appropriate analgesia, that causes a different type of psychological trauma. And so are we trading one for the other? And then, of course, there's anesthesia-related issues as well. But the overarching factors that contribute to negative and traumatic birth experiences and the increased risk for PTSD: feelings of helplessness and loss of control, minimal support, fear, and negative subjective experience of childbirth. So not only do we have this research telling us what's associated with trauma, we also have patients sharing their narratives. These come from my clinic, just a few. They told me I had a bigger baby and was scheduled for C-section. They separated me from my husband. I remember being strapped down. "You're going to feel pressure," they said. I felt everything. I screamed, but they continued. They never brought my husband in. I remember vomiting a lot. I felt like I was gaslighted and no one listened to me. The parts of this story I cannot forgive are the parts that are standard practice. Imagine for a moment being a rape survivor who's been tied down to a bed, naked or nearly naked. That should never happen to any conscious person, not in a calm planned surgery and not in an emergency. The straps were even a greater violation than the catheter. Those straps have haunted me every day of the 2 years since my daughter was born. Those straps broke me. This is a graphic novelette that a patient shared with me about her birth narrative, and I picked out this particular cell because we learn a lot from these patient expressions, patient narratives. Why is this happening to me? Why can't they just get it? What is taking so long? This is torture. I'm in so much pain. I can't handle this. I need this to be over. What is so wrong with my body that they can't place this thing? So what do we learn here? That there's a lot of self-blame that goes into these situations. So we might think they're angry at us, but often they're angry at themselves. So we wouldn't know that unless patients felt safe enough to share these narratives. We also have the retrievals. So patients are going on their own podcasts. This is a big one that just came out in July. If you haven't listened to it, I highly recommend that you do. Again, we're hearing the patient side of things about what is happening, what is traumatic to them. And then we have the consequences. What happens after birth trauma, whether it was re-traumatization or traumatization for the first time in obstetrics? These are just some. Patients can dissociate due to fear or pain, and it could be a coping mechanism that they are used to, and they don't remember the birth. So, as a coping mechanism that once might have been life-saving for them, now causes them to have guilt, sadness, and possibly postpartum depression. Some are angry after traumatic birth experiences. They get hostile. They leave early. They don't come back for postpartum care. They don't come back for antenatal care next time. They write you up on social media. They go on podcasts. They switch providers. They're angry. There's psychological harm that impairs the ability to breastfeed or bond or have attachment later on. And that can impact the children later on in life. Even the maternal-fetal bond, if there's trauma during pregnancy, we see higher rates of IUGR, hypertension, and preterm delivery. Mental health complications, depression, PTSD, OCD, suicidal ideation, psychosis, anxiety. It's more than just depression. It's a lot. Pain perception. People with mental health disorders often have altered pain thresholds, including those that come from trauma. If we're not careful and we don't pay attention to that, they can have acute severe pain, maybe even develop chronic pain states. The birthday of the child often falls on the anniversary of birth trauma. So that birth trauma lives with them all the time. Unless they get help, this is a very difficult day for them. Some choose to never get pregnant again. Some choose to not come back to the operating room even though they have a T incision, and they say, no, it was too scary. I'll never return to an operating room. I'd rather deliver my child at home than come back. That's how powerful birth trauma can be. And it doesn't only impact the patient. It impacts us, right? These are some interesting data. 18% of obstetricians and residents report significant PTSD symptoms, according to that study. I had a hard time finding studies that looked at anesthesiologists and PTSD. But this is one that I found. Almost 21% had probable PTSD after COVID. Right? So trauma can impact us, and then it leads to job dissatisfaction and burnout. Morbidity is not the only issue that comes after traumatic birth, but we also have mortality. And I'm not going to belabor this point. We've seen this data all morning. Mental health, trauma-related conditions contribute to a significant percentage of maternal mortality. Okay. There we go. So just to conclude, I wanted to bring up a slide to make us think, or get us thinking about what's our role in all of this. I think for a lot of us in the space, primary prevention is where you can offer the most. And that is, how do we prevent trauma? What can we do to ensure an environment of physical and psychological safety? What can we do to give patients a sense of choice? There are people doing different research projects out there now. Some are looking at including screening questions on their intake for the anesthesia pre-C-section EPIC board. Some are studying whether or not bringing patients to the operating room before the surgery to desensitize them, familiarize them, give them an immersion experience can decrease anxiety. Some are learning how to sit when they talk to patients and not put their backs to them while they're on the computer, right? And all of these things. And then we're going to hear more about pain during cesarean delivery. What can we do to minimize that trauma and keep patients safe? Secondary prevention is what happens after we think there's a traumatic event. What can we do? Well, one thing we can do is not turn away. We need to make contact with the right referrals. If you have some idea that this person had a difficult experience, tell somebody. Tell the next staff that are coming in, report that to postpartum, so this person gets the support that they need in that time frame. There is some data that using a visual spatial task or even playing Tetris can be beneficial within 6 hours of a traumatic experience for patients. If they play it for 15 minutes within 6 hours, decreases the incidence of side effects, PTSD side effects at the 6-week mark. Perhaps we can study that for providers as well, but trying to implement something like that might be useful. Tertiary prevention. What happens after they've been diagnosed with PTSD? What can we do? Well, we can do lots. There's stellate ganglion blocks happening, and that's an anesthesiology specialty. The team at Stanford is looking at dream sequences or emergence from general anesthesia and looking at dreams and trying to understand what that is doing to allow the processing of traumatic memories. So there might be a role in any of these phases, but there is a role for all of us somewhere on this to help to promote better outcomes. And then just to conclude, this is my favorite slide. What do I ask of all of you? It's curiosity, if nothing else. Can you please think about what's behind the curtain? We meet people in a very short period of time, and it's a very stressful, vulnerable period of time. So if we can open our mind to see what's behind there, I think we can promote better collaboration and get better outcomes. Thank you. I hope I wasn't too far over.